So good evening, everyone. Thank you for joining us today. Hope we're all doing well. Welcome to an informative discussion on the learnings from the last few months of COVID treatment and, discussing things like lung fibrosis, whether it's reversible, whether it's actually fibrosis. We have with us Dr. Sujeet Rajan, and I will introduce him shortly. Let me quickly recap what Patients Engage is about. We are a digital platform operational for over 5 years and focused on holistic and evidence-based management of chronic conditions from the perspective of patients and family caregivers. We believe in the value of lived experiences and strongly urge each and every one of us to be better informed and proactive about managing health and chronic conditions in order to improve our quality of life in the long run. We have been running a series of webinars which allow you to interact with healthcare professionals as well as persons with lived experiences. Today we have with us Dr. Sujeet Rajan. He is a respiratory physician who graduated from Grant Medical College in 1989, postgrad in respiratory medicine, and he joined the Bhatia Hospital in Mumbai in 1996, as well as joined the Bombay Hospital Institute of Medical Sciences from August 2000. He's been actively involved in teaching, research, and clinical practice at these two hospitals. And his areas of interest are interstitial lung disease, airway disease, sleep disorders, and patient communication. And he's set up an ILD clinic, which runs twice a week. He's also on the European Respiratory Society's national representative from India and the editorial advisor for the American Journal of Respiratory and Critical Care, and has numerous publications to his credit. He can be contacted on the email ID given below as well. So we are very pleased to have him with us today. And my colleague, Dr. Sheetal Patel, and I, Aparna Mittal, will be moderating the session. We will start with a few questions, and you can send in your questions either in the Q&A in the Zoom, or you can also post them if you're watching us on Facebook Live. You can post them on the live feed. Please do note that this does not replace a medical consultation, so you need to organize a separate consultation for specific medical issues. And as always, you can follow us on patientsengage.com or any of our social media pages on Facebook, Twitter, Instagram, YouTube. All of the webinars we do get recorded, including this one, and they're put up on our YouTube channel. And you can reach us at editor@patientsengage.com. A quick reminder that on Tuesday, 11 a.m., we will be talking to Dr. K. Srinath Reddy, President of Public Health Foundation of India, on COVID-19 vaccines, facts, and misconceptions. So I won't take too much time. Let me get started on the discussions. Thank you, Doctor, for joining us today. It's a Saturday evening, so I know it's your me time and your personal time. So thank you for taking this time. Let's start with what are, in your views, because you've been working on COVID treatment for a long time. What are some of the misconceptions that you are still coming across, and what people really do need to understand?
So Aparna, thanks for having me here. Always a pleasure to interact with an audience that is possibly patients or people who could be talking to patients and helping them, guiding them. So there have been quite a few misconceptions, and I think primary among them has been the fact that COVID needs a lot of vitamin supplements. I think that should be clear to most people that you don't need an antibiotic for a viral infection. And so if your doctor prescribes it, just have a word with him and ask him whether, why is he prescribing an antibiotic? And then I think you may get a more appropriate prescription. You would also probably want to know that many, if not most, COVID patients respond to no treatment at all. And so
Mm.
just watchful observation and good supportive care at home, rest, hydration, moving around in the room if you feel up to it is fine. And this is another misconception, that people need to be completely bed rest. It's not required at all. CT scans is another misconception. I think too many people are getting too many scans done. I think your audience needs to understand that 95% of COVID patients will have some abnormality on the scan. And so please don't do scans. I mean, I see people having 2, 3 scans and all that, and they're really not required most of the time. In fact, a hospitalized patient, most of the scans done. And finally, I think one more misconception probably, Aparna, is that all elderly patients should get admitted to the hospital. Again, we don't do that for seasonal flu. And I think if you have fit elderly patients who are intelligent enough to monitor themselves at home, there's no need to rush them to a hospital. Be in touch with your primary care physician. Of course, comorbidities, and there are certain reasons you would, but we can come to that. But
Right, right,
that's another misconception.
right, right. So I guess the question then is that, and we also have the other extreme of people who will say it's just a viral and they won't get themselves tested. It's a normal flu. So do I need to get myself tested? Um, how do we balance the two? And,
Sure,
what precautions should those people
sure,
take? Why is it
sure.
important to know that it's COVID
Yeah,
and,
so
not a
it's
normal flu?
right. It's definitely not a normal seasonal flu. We have seen that, and across the last few months in Mumbai, seeing all these patients, they don't behave like flu patients at all.
Mm,
The muscle aches and body pains and fatigue, there are very few symptoms that mimic the flu, which is like a constant runny nose, blocked nose, change in voice. You don't see any of that in COVID.
mm,
So you have to be clear that this is a different infection. This is a different virus. And if I had to say fatigue was a symptom, then I would just multiply by 5 times for seasonal flu. Give you an approximate. So seasonal flu patient gets tired. So for a little longer haul in for those who have symptoms. And there are many patients who don't have symptoms. So then you don't have to worry at all.
right, right. Um, So what is if you're monitoring at home, what should you be monitoring
Yeah.
to make sure that you're not letting it escalate or you're not uh,
Um,
neglecting?
so there are 4 things now. Blood pressure instruments should be in patients' homes, especially patient homes where there are elderly patients. Pulse rate and oxygen saturation you can get with a pulse oximeter, which I think has now become a household item. Was always an instrument in the chest physician's clinic. Today, most households seem to have one. And I would say glucometers for diabetic patients to just be sure their blood sugars are not going up and down.
Mm,
So these things, if you have these things at home, you can monitor pretty well and relay to your GP what is going on. So I think that, Aparna, makes a big difference. If you're able to get these parameters across to your family doctor, I think he'll be able to monitor you pretty well.
right, right. Okay. Um, and when do
I have a quick question.
sure, sure.
Sorry.
Go ahead.
How often should patients be monitoring themselves? Is it like every 6 hours, twice
Yeah,
a day?
yeah.
What
You don't
is
want them. You don't want them, Sheetal, to be obsessive also, because obsessive lands up with patients checking their oxygen saturations every few hours. And honestly, if your fingers are a little bit cold in an air-conditioned room, there's going to be poor circulation in the fingers, and you'll get 1 or 2 readings below 95, and then there's panic. So we do tell patients not to do that. If they have symptoms, for sure monitor, and maybe more than 2 or 3 times a day. But if they don't have symptoms or very mildly symptomatic, once or twice a day is enough. And be in touch with your primary care physician, at least the first few days. And if you see 3 or 4 days of hardly any symptoms, then I think you're most likely out of the woods. And unless you're an elderly patient, where we prefer to discharge them from the hospital only on day 10. So if you have first symptoms on the 1st of November, we would only discharge an elderly patient on the 10th of November, provided 8th, 9th, and 10th November are symptom-free days.
Okay.
Right.
So are they less infectious after the 10th day as
That's
well?
right. That's right. Much less
Right.
infectious. So you're almost non-infectious by day 11, barring those patients who are really severely ill, who have needed intensive care. We'd probably stretch it a little longer for those patients, and sometimes you need to stretch that for one more week. And so that's why for very sick patients, to shift them from a COVID ICU to a non-COVID ICU or a ward, we want a negative swab. But otherwise, we don't do repeat swabs at all. So most patients have cleared the virus. You will not be able to grow the virus at the end of 2 weeks, and in 95% of patients by 10 days itself. Elderly patients sometimes have the virus till 3 weeks. I'm talking about culturable virus, Sheetal, not the PCR being positive.
Okay.
And one India, which is Pune, National Institute of Virology, that grows the virus in a lab. And if you cannot grow the virus, the patient is not infectious, right? But we can't send all our samples to Pune. So even in the United States, there are very few labs that actually culture the virus. So in the absence of that, you look at symptoms and say, common sense tells you that if you're below the age of 50, you've cleared the virus at 2 weeks, 100%. And if you're above the age of 50, maybe stretch it to 3 weeks. And that's why home quarantine is recommended for up to 20 to 21 days at times.
Okay. Thank you.
Thanks. I think there's a question on the oximeter. We may as well take it now.
Sure.
What values on oximeter is a red flag?
So consistently, Aparna, below 95 is a red flag at sea level. But I have to add here sea level. Okay, so when you have the audience is living above a certain altitude, you are going to have a lower baseline saturation. So if you're living at, say, 3,000 or 4,000 meters above sea level, some cities in the world, your resting saturation is 90%. That's normal, 89 to 90. So you have to look at it from that point. So assuming most of the audience is living at sea level, then 95% and above is what it should be. And if it just goes as one-off readings, now if you're, as I told you, a cold finger, it can drop a little below 95. If you're obese, you have a huge paunch, that's going to push on your lung. So it could go a little lower than 95. If you lie down and you're overweight, again, there's push on the lung, it could go a little below 95. So if you're sleep apneic and you lie down, it can definitely go and stay steady at 92, 93. But that doesn't mean you've got lung involvement with COVID. So you have to put it in a context. And I think that's why your GP is a good person to ask and to make sense of that saturation. Otherwise, you'll have multiple calls for false low readings, which you don't want.
Right. And I know you mentioned air conditioning, but we are in winter. So if you are in a colder place, then does that make a difference on the reading as well?
No, unless you have cold fingers. The colder climate won't make a difference. But if your fingers get cold, the pulse oximeter detects the oxygen saturation based on circulation at the tip of your finger. So if that's getting frozen, you're going to have poor circulation, low reading. And it happens in our clinic all the time. When patients come in, if my clinic room is excessively air conditioned, we will get a low saturation for routine patients.
Right. Okay. I think you kind of already answered this, but there's a question. Is it true that we shouldn't meet corona patient for 2 months as they still have a chance to spread?
Oh, no, not at all. I think that's a big misconception. 2 to 3 months, I would say, Aparna, they can have a PCR positive on their throat. And that does not mean that they are infectious. I mean, I would like everyone to understand this because so many people panic when their swab is positive, and we have had patients who are in the ICU for 2 months and their swab is positive. So you can meet a patient safely if he's below the age of 50 after 2 weeks. And above the age of 50, I would say go and meet the patient after 3 weeks. Before that, just wear PPE, take care, distance yourself. That's important.
Right. Okay. And you already talked about, so I guess the question of swabs is there a need for repeat swabs, and how often do you recommend?
No, we don't repeat swabs at all.
Right.
In fact, the Indian Council of Medical Research, ICMR, does not recommend a second swab, and you should never use a swab for monitoring the patient's infectivity. The only time you probably repeat a swab is for those very rare cases who have, had another bout of fever, maybe after 3 months, and you suspect relapse of COVID, which there are a handful of cases reported worldwide. And so I would reassure everyone that relapse of COVID is not at all common. Having said that, there you may want to repeat a swab, and such patients should be cultured to see if they have culturable virus, to see if it's a true relapse or it's just a positive swab from the last infection. But otherwise, the reasons to repeat swabs or do a second swab is only if the first swab was negative and you strongly suspect COVID, because we know it has a 30% false negativity rate. And maybe a third time in a highly suspicious patient where you think everything is fitting in with COVID, the patient is sick, dropping oxygen, and you don't want to expose that patient to other patients. So then you would keep him in a COVID suspect ward and do even a third swab sometimes before shifting him out.
Right. And I think there's a follow-up question. I think you said it's not common, but do we have any stats on how common is the relapse of COVID?
So we've the last I read, which was about 3 weeks ago, was about 26 cases reported worldwide. 26 cases out of probably already
a few millions.
Millions already is really small. So I think that is reassuring, to say the least.
Right. And I think you said let's talk about comorbidities. So if a person has comorbidities, does the type of comorbidity impact does it change the way you have to monitor and care?
So the commonest comorbidity is hypertension. And from my rounds in the hospitals, in both the hospitals I work at, hypertension has been the commonest denominator as a comorbidity. The second most possible comorbidity is diabetes and obesity. So we have seen patients who are overweight having a more stormy course. And chronic kidney disease. Chronic kidney disease, the risk, my nephrology colleague has done a short analysis of his patients because he has a full database. So patients with chronic kidney disease definitely have a higher risk of getting COVID and a higher risk of mortality. So those are the patients to be careful about. Interestingly, our transplant patients are not doing that badly. And we sometimes wonder why. I mean, at least they aren't getting COVID that often, and maybe it's because of a low level of immunosuppression that is going on.
Right.
So we haven't understood that part well, but I have 3 post-lung transplant patients in Mumbai, and none of them have had COVID, fortunately.
Maybe they're also extra careful, right? I think when
to the hospital into a COVID suspect ward with fever. And I was, horrified that she would get COVID, even though she had a urinary tract infection. And I can't tell you how relieved I was when the swab was negative. We wanted to almost send her out by express courier out of that COVID suspect ward into the non-COVID section. But she's doing well, so that's where you come to the story of whether this low dose of steroid tablets that some of our patients who need them could possibly be protecting patients from severe COVID or from COVID itself. But we don't know that. There is data.
Right.
I think that would be good news for all the patients who are on immunosuppressants.
Exactly. And
because I think there was a big fear earlier about
so
low immunity.
March and April, we were actually telling or considering telling our patients who were on azathioprine, methotrexate, and all these immunomodulating drugs to possibly reduce their dose or be very careful.
Correct. Yeah.
And now when we look at the data and worldwide this is coming out, patients who are on these immunomodulating drugs are probably at less risk because COVID, as you know, creates a hyperimmune
Right.
6 to 10 in some patients. And that hyperimmune response could be attenuated with these drugs. So we don't know the reasons, but there's some cheer for those patients at least.
Absolutely.
Right. I guess it's always good if there's any positive news like that.
There's a lot of positive news in practice, but I can come to that later if you want to ask me.
Yes, I think we all need positive news as well. So I think it's good.
Sure.
There's
Yes.
another follow-up question. Can we always assume that antibodies have been developed for COVID after 2 to 3 weeks?
No, you can't assume it's always there. But as I said, the incidence of reinfection is so low that you may not need neutralizing antibodies, which is IgG, for those who want to know, IgG to COVID, in
Hmm.
your blood to offer you protection. So the
Right,
absence of an antibody does not mean that you are not protected. You still have your T lymphocyte cells, which could protect you against infection, which are memory cells. So they have a memory capability of recognizing the virus, which was previously exposed to those cells, and they're able to deal with it. So you do have immunity for sure. We don't know how long, but I do know that now at 9 months, I can tell you that for 6 months at least, patients have had antibodies. I have colleagues who have had COVID and the antibodies are positive in their blood 6 months down the line, which is pretty good. And I think we'll
right,
see it for longer, hopefully.
right. Okay, good. Sheetal, go ahead with your questions. I'll check what are the
Yeah.
questions coming in.
So some of the patients had thrombosis
Yeah.
as a result of the COVID. So
Yeah.
um, what is the protocol for discharging such patients, and are they put on blood thinners?
First of all, Sheetal, please understand, and this has again created a lot of scare among patients, that everyone with COVID is at risk for thrombosis, which is really rubbish, because
Mm.
that's why a lot of patients are unnecessarily getting blood thinners, which are not required routinely.
Right.
So they saw it on post-mortem data in Italy that a lot of dead patients had clots in their pulmonary vessels. But what it just means is that if you do get into that hyperimmune or thrombotic state, and that usually happens in severe COVID, then you are at risk. And so in those patients, we would monitor the D dimer, which is a blood test, and look for, which is a clot degradation product. And if those levels are high, you would definitely give a preventive blood thinner, 1 dose in the hospital. And if you have to give it in a therapeutic dose, those levels have to be very high, or the patient's oxygen has to be low enough, or then you may want to get a CT scan with contrast to confirm the patient has clots. And when you do that and you confirm the patient has clots, you are able to confirm he needs blood thinners and then obviously give him a strong blood thinner when he leaves the hospital. Because if you haven't confirmed that, Sheetal, you are subjecting elderly patients, which I'm seeing day in and day out, subjected to blood thinners, which are potent. And if that elderly patient has a fall, he's going to bleed in the brain. So please be careful. Ask your doctor,
Right.
what is the evidence for me to be on a blood thinner? And then some doctors are giving aspirin. There is no evidence on giving aspirin either, unless the patient has coronary artery
Mm.
disease or a stroke. Why are they saying aspirin is like the second best blood thinner? Not at all. If he needs a blood thinner, he needs a potent blood thinner. And there are 2 or 3 drugs in that group, rivaroxaban, dabigatran, and warfarin. And those are very potent drugs, should be given carefully. And the patient should be told that if he goes for any procedure, even a tooth extraction, the surgeon should be informed, and should be very careful about not falling or injuring himself.
Okay. And regarding the use of steroids, we know in the US as
Yeah.
well, the
Yes.
president himself got steroids. So,
Correct.
again, there may be a lot of misconception around that. Can you clarify that for us?
So the US president probably got steroid because his oxygen saturation dropped.
Hmm.
And I think for any patients whose oxygen saturation drops, we would consider steroid.
Okay.
Now, it's important to understand that there is no infection, barring a rare infection in HIV positive patients called PCP, where you give steroids. I mean, have you ever heard of steroids being given for an infection? No one's heard of it,
No,
right?
correct.
Having said that, if that infection causes an inflammation which obstructs oxygen transfer from the lung to your blood, so the lung's function is transfer of oxygen into the blood. So that lining is called the interstitium, and that's an area I'm very much interested in. The interstitium of the lung is the lining, and if you pull that interstitium out, Sheetal, the area is as big as a tennis court. That's the amount
Okay.
of area our lungs have to actually transfer oxygen into our blood. Now, if that interstitium gets swollen because of the infection, we call that inflammation of the interstitium. That can respond to steroid because steroid is a very powerful anti-inflammatory drug. And so all the studies have shown that steroids help patients who have dropped oxygen. Okay, and that also not in large doses, very large doses, definitely not, and not for long durations of time. Both these errors are happening quite often. So people like to hit hard with some huge doses because they heard about steroid and they give it for too long, which creates infection issues, especially in diabetic patients. So this message should be, and if you give steroids where the oxygen has not dropped, Sheetal, you're likely to do more harm to a
Oh.
patient than good. And that's why the WHO came out with that recommendation uh, about 6 to 8 weeks ago that steroids can do more harm than good if you give them when not indicated. And you see steroids being prescribed quite frequently when not indicated. And I think that's
Mm.
something, again, patients should go back and ask their doctor. If this medium, patients engage, is doing one thing that I would really hope for, is that patients or the audience goes back to their doctor and asks their doctor the right questions. And the problem is that they don't get the time and the width in that consult to ask the doctor because he's in a hurry. But then I feel the whole consult has failed. So if you're not able to get a simple question of why you should take a drug that has so many side effects for your infection, in inverted commas,
Mm.
not inflammation, then I think you should be, questioning your doctor more or changing your doctor. Because I get very upset with doctors who don't clarify this, to their patients clearly.
Doctor,
Um,
sorry,
yeah,
I
go
think
ahead.
there are a couple of questions around ILD and lung fibrosis, so if we can cover those as
Sure.
well.
So that
Yeah.
Yeah, go
on
ahead.
ILD, yeah, ILD is
Yeah,
something,
yeah.
I'm passionate about. But the thing is that I think the audience must realize that post-COVID, you don't get a lung fibrosis that progresses, and yes, it does progress in those first 14 to 21 days, but now we are 9 months plus into the pandemic, and we have seen so many, in fact, the majority of these so-called fibrosis patients improving. So it's a bit of a myth. There was an article in the newspapers also that this lung fibrosis is going to be a tsunami of lung fibrosis.
Mm.
We're seeing
Mm.
lung involvement with COVID, which is getting better. And it's getting better naturally by doing nothing, by interfering a little less, maybe a little steroid for the first few weeks. Okay, and maybe an anti-fibrotic drug on which research is still going on. So sometimes we're giving those patients an anti-fibrotic because the side effects are much less than steroid. But I can tell you confidently that at 3 months and 6 months, we have more than a couple of dozen patients now who have completely cleared this so-called fibrosis. So that's a good sign. Having said that, some patients are left with some scars, and those who suffer most, of course, are those with previous lung disease, Aparna,
Right.
because they already have a reduced vital capacity. On top of that, if you're going to damage interstitium, you're going to have even a lower capacity of your lung. They will suffer more. They will have more long-term sequelae, unfortunately.
So we do have some of our audience is people with ILD, with pulmonary hypertension. So that, there are a few questions from those people as well, and some of them have had
Sure,
COVID as well. So just so that
sure,
you're
sure,
aware.
sure. So I hope they've all recovered. But if they have had if they have an ILD, I hope their lung function has not dropped further. The good time to probably recheck their lung function is about 3 months after COVID. That's a safe time to do the test and to see if you have lost vital capacity after suffering the infection. But rest assured, even if you have, you could still recover 3 months down the line. So they shouldn't panic.
And is there any specific rehab therapy or
I
any
would
exercises or anything they need to do?
I would ask them to probably meet a cardiopulmonary physiotherapist. That's an MBPT. The qualification is usually a little more than a graduate in physiotherapy in cardiopulmonary. They are the best people to advise rehab. But short of that, I think any good physiotherapist who understands a little bit about cardiopulmonary rehab, because some of these patients, their oxygen drops on walking, and some of these patients, in fact, most of these patients don't just need lung physio, they need arm and leg physio as well, because day-to-day activities are not done just with the lung. Your limbs are required. So a good cardiopulmonary physiotherapist understands that.
Right. And is it common for people to feel chest pain when they talk and speak post-COVID,
No,
even if they're recovered?
not really. So chest pain, the lungs don't have pain fibers. So even if you have a growth in the lung, it doesn't pain you, right? Even if you have a lung cancer sitting in a lung, there's no pain until the cancer moves to the pleura, which is the outer surface of the lung or the chest wall. That's when the pain comes. So the pain is all skin, just below the skin, soft tissue and muscle. So you shouldn't get pain, chest pain, unless you have an associated vitamin D deficiency, the commonest cause, or a muscular myalgic pain, very common with viral infections, or cardiac. And if it's a cardiac pain, it usually gets worse on walking and exertion, as compared to a pain of, say, reflux, acidity, which will get better when you walk. So if you're not sure whether this pain or discomfort behind the chest is acid reflux or cardiac, take a short walk. And if it gets better, it's more likely acid reflux.
Right. Okay.
Maybe
We
a
have a
word about
question.
asthma,
Yeah,
if
Sure.
I may say,
yeah,
Sure.
sure.
Aparna,
Sure.
because it's not all chronic lung diseases that do worse. In fact, interestingly, the data has shown that asthma, which is one of the commonest lung diseases, there is no increased incidence of COVID in asthma patients. And I need the audience to understand this. In fact, mild asthmatic patients have been seen not to get more severe COVID. However, severe asthmatics, if they get COVID, are probably at a little more risk of complications. And so asthma to some extent seems to be protective. And this is very important because in March, April, the CDC put out a recommendation about asthma being a big risk factor for COVID. And a lot of our asthmatics got worried.
Mm.
And we had to allay them. And I think they got worried because they saw it as the first illness on the list. And that was
Right.
probably because of alphabetical order rather than actual severity. And so now we know that the incidence of asthma in COVID patients is less than the general population, one study has shown. So whether it's the steroid inhaler or the disease, we don't know, but there is some protection.
Right.
And I think that's good news for asthmatics in general and should reassure a lot of. We called up about 170 of our asthma patients on our database 2 months ago, and only one had had COVID. Only one. So
Right.
that is low, in my opinion.
Yes. Good. Thank you.
And what are the stats for patients who have ILD or COPD?
So there is no statistic. I think the incidence is not increased in them, Sheetal. It's probably the same as the general population. It's only that if you have a lower lung capacity and you get COVID, you're probably at a higher risk of getting more sick with the COVID. The other corollary is that if you're on an immunosuppressant or an antifibrotic, a lot of ILD physicians, which is the group I interact with globally, have seen less COVID in these patients. So we don't know if ILD and the COVID virus have somehow a common pathway in their mechanisms, which is why they're less at risk of contracting COVID in the first place. Or as Aparna mentioned, are they just protecting themselves more? We aren't sure about that as yet.
Right.
Right.
Okay. A couple of questions, Sheetal, I'll start taking them. I have autoimmune disease, scleroderma with mild ILD. What necessary precautions do I need to take to not get infected? And if I get, what should be the extra precautions since I have small kids as well?
So scleroderma and ILD this patient is probably on an immune suppressant, either low-dose steroid or mycophenolate, azathioprine, more likely mycophenolate, and probably if she has lung disease as well, an antifibrotic. So that's the current. Keep the lowest dose that you need is what I would recommend as a respiratory physician. Talk to your current physician about it. Avoid the usual precautions, avoid going out unnecessarily, and do your follow-up with your doctor in the hospital. I mean, I think that is important. Many patients are not going for their routine follow-ups, and I think Aparna, I cannot tell you how detrimental that can be to health when you do not do your routine follow-ups and you will end up neglecting a chronic ailment. Especially if you need guidance, at least do it online and ask your doctor online whether the doctor would prefer to see you in clinic, and you will get the answer pat then, because I think there's a difference in meeting in a clinic in terms of just body language examination over an online consult.
Right. One question, do you recommend 24/7 oxygen for those who have developed fibrosis or lung scarring, as you call it, until there's reversal?
Unless their oxygen saturation is below 90%, they will not need supplementary oxygen. So in fact, we use a cutoff of 88%. So if you're 89, 90%, your pulse rate is reasonably stable, and you're sitting down doing nothing, you need not take oxygen. Oxygen is a drug which has its own side effects. If you're below 88%, most of the time, you need supplementary oxygen most of the time, okay? And so for our patients with chronic lung disease who have always got a saturation below 88, we recommend at least 17 to 20 hours of oxygen. Having said that, there are patients who are 91, 92, Aparna, who if they just take a short walk, drop below 88. And those patients we are advised to take oxygen during activity, if they're going to be talking a lot, physical exercise, their physiotherapy, going to the bathroom.
Eating, I hear of cases where after eating.
Yeah, so eating is not as strenuous, but some patients find it a strain, and so you want them to take their oxygen during their eating time. Passing a stool for many patients is quite a strenuous activity, so we tell patients to sometimes, even if they're 90, 91, hook on the oxygen for 5 or 10 minutes, go to the washroom, finish passing, and then come back, keep it on for 10 minutes, and then take it off. Because that way, and what patients do, the mistake they do is they do the physical exercise or the physical activity, come back, they're completely out of breath with a low oxygen saturation, and then put the oxygen on. By then, the strain or load on the heart has already occurred, which you didn't want to happen in the first place.
Right. Okay. Couple of questions on medicines. I don't know whether you want to address it. I'll just ask and you can decide. How long does an ILD patient need to take Medrol? My mother is taking it for the last 3 years.
Oh, so that's a question on ILD, Aparna, and Medrol is a steroid. I can tell you from my experience that regular oral steroid is rarely required now in ILD. In fact, we treat less and less patients with regular steroid for about 4 to 6 months. They may require it initially, and then you try and put them on an alternative immunosuppressant with less side effects. Having said that, there are some diseases like sarcoid where you need to give it regularly, and some patients who have just got dependent on it. So their body, because of misuse or long use in the past, can just not get off it. But
Right.
increasingly, the trend is to get the patient off steroids within 4 to 6 months itself.
Hmm. Okay.
So I would ask the
There's
patient to talk to a doctor about that. That's
right. Yeah.
important.
Right. There's also one question on sarcoidosis. Is there any other option other than Medrol to treat sarcoidosis?
Sure.
Sarcoidosis. Sorry,
Sarcoidosis. Sarcoidosis
sarcoidosis.
is like the TB. The amount of TB we see in India, we see sarcoid in the West. The pathology is very similar to TB. 80% of patients with sarcoid don't need any treatment,
Hmm.
and about 20% may need steroid. But again, I would emphasize that aim should be to get the patient off the steroid. The second line drug for sarcoidosis is methotrexate. And so methotrexate can help you to get the patient to the lowest dose of steroid and very often off the steroid. And having said that, many sarcoidosis patients can get off the steroid in 1 or 2 years. Okay, there is a small minority, about 20%, who still need the steroid tablets even after 2 years. Okay, but there is a minority. That's a minority.
Uh, okay, I think one more scleroderma and ILD question. Right now, I'm suffering from cough from last 1 month. Due to this, I have high heart palpitation. Any advice?
Oh, well, I think I would advise that patient to consult their doctor. But having said that, you must remember the other common problem with scleroderma patients is pulmonary hypertension. The lung artery pressures go up. So I'm assuming this patient has had an echo done to check for that. Cardiac problems do occur in scleroderma. So you may want to just check your echocardiography. You are dropping oxygen on walking, so you may want to take oxygen more regularly. But if it's just an anxiety related increase in your heart rate, there are drugs to just bring down the heart rate, which your doctor will advise you. Also check for thyroid issues and check for a low iron level in your blood. Both of them can cause what is called tachycardia or a high pulse rate.
Right. And how soon after you've recovered from COVID can a person kind of get back to full regular exercise?
We individualize this, Aparna. We don't want people doing too many things too soon, especially the elderly. So we tell patients to plate, listen to their body largely, and probably do short walks initially, increase every few days, and get back to their normal routine by 2 or 3 months, unless, when they increase, they have a problem. In that case, we would tell them just slow down, check, and they feel that, look, they can't even reach 50 to 70% of their original exercise capacity. I call them back to clinic because we need to be sure that they've not developed some post-COVID cardiac issues or lung issues. Most of the time, they've not, they're just a bit deconditioned and tired. That's what I've seen most of the time. Or they've got frightened by reading about long haul COVID, which I feel has frightened a lot of patients. So many patients who feel weakness for about a few days after the COVID are already discussing long haul. And I say, look, we're just on the short haul right now. Don't worry about long haul right now.
What are some of the common lasting effects, especially in the elderly? I
So
think long haul is affecting elderly more, right? Compared to
yes, because they're already frail, Aparna, and that's why they are getting more affected. So anyone who's frail, and look, there are elderly patients who are 75, 80 years old who are very fit and who have passed COVID without a single symptom also. So age is a relative thing. I always feel frailty. You can have a 50-year-old person who is extremely frail.
Right.
You can have a fit 80-year-old. So frailty is becoming more important in geriatric patients.
Mm.
And so the person who's already sedentary, overweight, elderly is going to suffer much more post-COVID problems than a 70, 80-year-old who's been going for a regular walk, physically active, and not smoking and not having too many comorbidities. So the host factor, as they say, is very important. How good is the host immune response, and how much is the virus load that they got?
Mm.
So an elderly doctor, for instance, sitting in a clinic with comorbidities himself or herself is at much higher risk of problems because the viral load they'll get from a patient is higher.
Right.
And that's why we haven't seen many of our senior doctors coming back to work.
Yes.
And, I think for good reasons sometimes, which is really a problem in the hospitals actually.
And there's a question on the time that you need to have spent with someone who's COVID positive to get infected. Is there, what's the research on that, and
So
what is the relation to the viral load?
I have to confess, I don't know the evidence on that. I know that Singapore
Mm.
uh, has had some very interesting criteria on 15 minutes less than 3 feet apart is high risk contact. So I think anything more than 15 minutes and with a distance less than 3 feet is this is a highly infectious virus. Please understand that, and that's the biggest difference from seasonal flu. And that's why we need to get family members or other contacts at home tested. So I've seen sometimes the primary care physician telling the patient not to test family members, and I think that is not a wise decision all the time because you'd rather be a little heads up on this virus than not.
Right. Right.
Unpredictable sometimes.
Right.
Yeah. I think commonly what is happening is if the family members are not showing any symptoms, they tend to not test themselves.
Yeah, but you don't want to be surprised, Sheetal. I can tell you if you have a family member with comorbidities, that person is at a higher risk of getting complications. So I would test 5 to 6 days after the patient had first symptoms. So if a patient had
Okay.
symptoms on 1st November, to give you an example, and quarantined himself, then I would test the contacts on day 6, day 5 or day 6. That is the highest yield you'll get. And if they're negative on day 5, 6, it's very unlikely, and no symptoms, as you said,
Mm-hmm.
very unlikely they have COVID.
So I think there was a question, and I suspect it's related to what we were talking before we started on the Delhi transplant. But
Right.
somebody's asked a question. We've heard of a few COVID fibrosis patients worsening and requiring lung transplants. So if you can talk about that.
Right. No, so I'm in touch with the lung transplant surgeons, quite a few of them in India. We have only a few actually. And till about the end of August, not a single lung transplant was done in India. Okay, and this is information from T. Sundar, who's the father of lung transplant surgery in India out of Apollo, Chennai. And however, from September, their transplant program started picking up, and they had done 6 lung transplants in September itself.
Mm.
So transplant work has gone back. Having said that, transplant for COVID has not happened. The Delhi transplant that you spoke to me about earlier, Aparna, was on a patient who had chronic lung disease and who incidentally had COVID. So the transplant was not done for post-COVID sequelae. He had COVID, he recovered from it. We
Right.
would not call that a post-COVID lung transplant. We have yet to see a patient with severe COVID being successfully transplanted in India, at least. I heard of one report in the United States, but I'm not sure.
Mm. Okay. There's a comment which says KIMS has reported having done a few transplants on COVID plus fibrosis. So we'll check that out.
I'm not aware. KIMS is in Hyderabad, if I'm not mistaken. I know the transplant team there, but I have not heard of post-COVID fibrosis patients being successfully transplanted there. And if it's there, it'd probably be in the media and in the press. So one could Google it because that would be big news for sure. And if it's
Yeah.
happened and I don't know about it,
Right.
I'm very happy. There
Right.
are patients, especially the younger patients with severe COVID, who do talk to us about it. And it is an option for sure. But please remember that, the ground rule in lung transplant is that if you walk into the hospital, you're likely to walk out.
Mm.
If you come in a wheelchair to the hospital for a transplant, you're likely to leave the hospital in a wheelchair. Uh, and if you come on a stretcher, which is what the post-COVID patient is likely to come in, you're likely to leave on a stretcher. Now, having said that, please understand this is not a panacea for post-COVID. I mean, lung transplant is not a simple surgery. It is the most difficult transplant of any organ. Even a heart transplant is easier.
Mm.
So we have to be very careful in selecting and referring our patients for transplant. And the patient and the family should be fully geared for the post-transplant scenario, which is hardly a cakewalk, even for the patients who do well. And so I think counseling is very important here. So they could do online consult with the KIMS team or the Apollo team, which are, I would say the Apollo team is one of the most experienced in the country, and do an online consult with them to understand the implications of undergoing a transplant.
Right. Right. Um, all right. There is,
There's a question on the,
yeah, go
yeah, the
ahead. Go ahead.
home treatment protocol, if any, for COVID patients, medicines, vitamins,
Yeah, I
steam
think patients are
inhalation,
I think patients are getting enough vitamins for their lifetime during COVID. So I'm not about
especially
that,
zinc, I think.
especially zinc. I know, I guess for that time period, if they are happy taking a vitamin, it can't do that much harm. Having said that, what I tell patients to do is just check their vitamin levels, B12, D, iron. I just tell a lot of COVID patients who are taking multiple tablets to just check B12, D, iron levels. And if they're low,
Hmm.
then correct it. If your D levels are normal, for instance, and you take vitamin D, you're going to get hypervitaminosis D, which means you're going to have giddiness and severe headaches. So we don't want that to happen to our patients. Having said that, the question was on what to do at home. I think there's nothing to
Yeah.
be done at home except quarantine. And please don't quarantine, which another mistake patients make, Sheetal, is they quarantine after their swab comes positive. Quarantine the moment you have symptoms. So if the patient has fever, a sensible patient will quarantine themselves straight away and not wait for the swab to come positive if you have the space in your house to quarantine. And that is a challenge in many parts of India where
Hmm.
you don't have a separate bedroom. And so that's where the importance of a COVID care center comes in, where you can safely quarantine, and
Right.
especially from elderly people in the home.
Right. There
And
is a question from someone who has chronic lung issues. Is there any stem cell treatment to regrow alveoli?
No, it's been tried. There have been two studies on it, and it's really not worked, not in lung fibrosis. So currently, the IPF guidelines at least do not recommend stem cells treatment at all, short of a clinical trial. So if you have a center doing a clinical trial, for sure. Like we are doing two clinical trials at our center, but on two investigational drugs for lung fibrosis. Once those are proven, it is to then go for a clinical trial protocol.
Right. What is the relevance of an antigen test post-COVID? Is it advisable?
Oh, that would be a disaster actually, because uh, antigen tests are good for diagnosis. They're rapid. You can get results in 15 to 20 minutes if the lab is your friend. In probably less than that also. Having said that, follow up, as I told you, antigens and PCR tests are not to be used for monitoring and follow up. So antigen tests for sure not. You get land up getting false negatives, false positives, left, right, and center.
Right.
so,
Okay.
in that context, what is the use of the antibody test?
The antibody test tells you have neutralizing antibodies to COVID-19. So you will have IgM antibodies that come up within 5 to 6 days itself, and IgG antibodies which peak by day 14. How long the IgG antibody remains tells you how long you have neutralizing antibodies. So we are very clear that you have neutralizing antibodies now for in most patients for up to 4 to 6 months. As
Right.
we keep studying how long the antibodies last, the longer they last, the better. Uh, and so, there's been talk about health passports, people
Ah,
flying with antibody test positive. So maybe that's a reason to test for antibodies. And people who have antibodies, can they still take the vaccine? That debate is still going on, but it is still recommended that they take
okay.
it. So I'm not sure how much and I guess people who've had an infection who haven't got tested, and you don't know if they had COVID, should get an antibody test done. So that at least 3 weeks or 4 weeks down the line, they come to the doctor's clinic and I say, look, you never got tested, but your symptoms and your x-ray now looks like you had COVID. I would like to get an antibody test to be sure you did have COVID. And finally, of course, for convalescent plasma donation,
Hmm.
antibody tests are important. However, there has been one negative trial, so the jury is not out on that. I think more patients are getting plasma than actually need it, but we still need more evidence in that space.
One question. My father is going through COVID treatment. He's 74. The CT scan diagnosis severity score is 12 by 25 with enlarged mediastinal lymph nodes. Will the lymph nodes inflammation recur once the steroids stop?
So, two, three things I would say here. First, I hope steroids have not been given for that CT score. The CT score is really meaningless. It doesn't tell you anything besides telling you how much of the lung is inflamed. How much of that lung involvement is causing a drop in oxygen is what you need to know. And so, if her or his father's dropped oxygen, then you need steroids, and you'd probably give it in the hospital for about 10 days, and then taper it off as soon as possible. As soon as the oxygen normalizes, actually, you should start reducing the dose of steroids. Otherwise, you'll get more harm than good.
Mm.
And the other question was what was her follow through question on that?
Will the lymph nodes inflammation
Okay.
recur once the steroids stop?
Right. So please remember, lymph nodes are not commonly seen in COVID. So if there are small lymph nodes, around a centimeter in size or below that, check how large they are. Then you would just ignore those lymph nodes and don't worry whether they reduce or they don't. But if there are larger lymph nodes, more than 1 centimeter in size, and quite a few of them, then you would want to repeat a scan at 2 to 3 months to see what's happening to them, and rule out any other illness that could cause lymph node enlargement. So that may be just an incidental finding you have found uh, on a CT scan. And that happens quite often. One of the commonest diseases since this question came up is sarcoidosis, which we discussed earlier,
Hmm.
where you can just have lymph nodes in the chest, no treatment required, and they can remain lifelong in the patient's chest.
Right. Okay. Um, is it true that regular breathing exercises help a patient with pre-existing lung issues? And do they help keep infections at bay?
For sure. So, well, infections at bay, they definitely keep the patient better off. So, breathing exercises in tandem with hand, shoulder girdle, and arm girdle exercises are very useful. And so that's what a cardiopulmonary physiotherapist specializes in.
Hmm.
That's the best level of supervision you can get for those exercises. But short of that, I would say breathing exercises are very good for airway disease like asthma, where
Mm.
you're emptying your lungs out better. So pranayam, yoga, pursed lip breathing helps a lot there. So overall, breathing exercises are a good thing to do, and especially they help you to empty your lungs out better.
Right, right. Um, I guess there has to be a question on vaccine. So, which vaccine would you recommend for ILD patients? Did any of them have fibrosis patients in their trials?
So for ILD patients, we recommend standard is a pneumonia vaccine. We would recommend the conjugate pneumococcal vaccine, single dose in a lifetime. For patients who are probably diabetic and have other comorbidities, we would recommend the polysaccharide pneumonia vaccine additionally after 1 year. And if the patient is below 65, they just need these 2 pneumonia vaccines a year apart. And another dose after they cross the age of 65 years or 5 years after the first dose. That's the polysaccharide. So the polysaccharide vaccine you can take twice in a lifetime, pneumonia only once. The other vaccine we recommend is the seasonal flu vaccine. So in Mumbai, it should be taken about a few weeks before the peak flu season. The peak flu season in Mumbai is May to August. So we would recommend, Aparna, that they get the flu vaccine in April in Mumbai. This year, we didn't give it to most of our patients. There was no seasonal flu because schools were closed, everything was shut. And so we had very little flu, which was great news, actually. But the second peak of flu in Mumbai is November to February. So in September and October, we have been vaccinating them. In Delhi, the peak flu season will be November to February anyway. So you would vaccinate in September, October. The other vaccine for elderly patients,
I guess the
vaccine, which
question here,
unfortunately is not available in India.
right?
But,
sorry, I think the question
sorry?
is likely to be around the COVID vaccine. So,
Right. So the COVID vaccine, I have to confess, I have no experience on the COVID vaccine. I've been reading a lot about it.
Yeah.
Yeah.
Do they include fibrosis patients in their trials?
I'm sure they would. I'm sure they wouldn't exclude them. I'm sure they wouldn't exclude. There's no reason to exclude them unless the patient refused to consent to take it. And as far as the vaccine is concerned, my classmate is the principal investigator at KEM Hospital. And she said for the AstraZeneca Oxford vaccine, we should have results by January end. And so we're waiting for results. I think there is no hurry. Please don't try and jump the queue for the vaccine. I think there's no point in doing that. We need to see the data carefully, like for any other vaccine, and then vaccinate our patients.
Right. Have you seen cases of livers being infected in COVID based on your COVID?
So not usually. What we do see is the drugs that we use for COVID, favipiravir and remdesivir, are both liver toxic. So remember, these are antiviral drugs, which is the only drugs we can really give to reduce viral replication. They don't kill the virus. We do not have a drug that kills the virus. So if you use an antiviral drug, use it as early as possible. Favipiravir, if you're at home, which is the drug approved by DCGI, and if you're in the hospital, remdesivir. And that also if you're dropping oxygen. Please remember, these drugs do not reduce mortality due to COVID, but they reduce the length of stay in the hospital and the duration of illness, which I think is fantastic news because hospital beds will be freed up. So
right.
I do think these drugs have a role, but they are liver toxic. So if you see liver enzymes going up in a COVID patient, worry more about the drug than the disease itself.
Right, right. Okay. I think we have overstepped our time. So I know we will keep getting questions, especially on COVID. I guess there's one question that's there. What's the best way to test, I don't know, ILD level, CT scan, PFT, or any other?
No. Okay, so the CT scan, as I told you, is not a great test to test the level. For post-COVID lung fibrosis, yes, but then it's after 2 to 3 weeks and should be read by a very good CT radiologist. Lung function you should not do during COVID at all because it's potentially an aerosol generating procedure and could land up infecting the whole lab while the patient does the test. So we recommend lung function tests not earlier than 1 month after the patient had symptoms or 2 weeks after a swab is negative, if you have to do a lung function. So we would say after 1 month, it's safe to do lung function. And that's how you monitor the patient's lung function, a good lung function test. That's the best monitor, or a 6-minute walk test if the patient cannot do a lung function test.
Right, right. Okay, great. Thank you, doctor. Thank you for taking the time to answer all the questions.
My pleasure, Aparna. I enjoyed it thoroughly.
Yeah, and I think it's been very useful, very, very informative. We've answered, I think, a lot of questions, and I'm sure we'll get a few more along the way as people watch the live stream. But I think, yeah, the feedback's coming in that it's been very useful. So thank you, Dr. Rajan. Thanks, Sheetal. And thank you to all our audience, and for all of you who are interested, on Tuesday we are talking on COVID vaccines as well. So watch out for that session. It's at 11 a.m. on Tuesday. We will put up the announcements on our usual channels. Thank you. Thank you, everyone.
Thank you. Thank you.
Thank you.
Bye.
Bye.
Bye.